Overall, you are welcome to this session. As our colleagues join, we would like to, in today's session, we are again discussing issues that concern our healthcare in our regions and our communities. And today, the topic we are going to be discussing is engagement of private healthcare providers in tuberculosis control. In today's session, we will essentially be getting experiences from Kenya. Our colleagues from Kenya will be presenting their lessons learned through this process. Generally, we know that you could have known somebody who have gone for healthcare services in a private setting, or some of us have gone to the private setting to get healthcare services. And this is usually for different reasons. It could be for socioeconomic reasons, it could be for vicinity, it should be for access and different perceptions. But it is important that while the private sector continues to provide these healthcare services, among which is TB, both treatment, diagnosis, and control, it's important that we engage the private sector such that we're able to know what is happening in the private sector alongside the public sector. In today's session, we will be getting experiences from Kenya, and we have a colleague who will be presenting to us. This is a colleague who is the national coordinator of the private partnership mix for the national TB program under the Ministry of Health in Kenya. Kirote will be discussing with us some of the strategies that have been established to enhance TB case detection and management, and how this has actually gone ahead to contribute to the government's emphasis on controlling this condition. At this point, I would like to welcome our colleague, Kirote Mwirigi, to go ahead and make your presentation. But at the same time, we encourage colleagues to go ahead and put your comments and chats in the chat box. During this process, Mwirigi will present, but at the end of it, we shall have a question and answer session where she will be able to respond to some of your comments that you have raised. Thank you so much, and welcome, Mwirigi, to go ahead and make your presentation.
Thank you very much, Silva. I appreciate this opportunity to share experiences from Kenya towards engaging the private sector in TB control. My name is Kirote Mwirigi. I'm the national coordinator of the engagement of the private sector to TB control, which we call PPM, under the national TB program. Most of them are member of the WHO PPM working group. With me, I have my colleague, Joshua. Please allow me to ask him to introduce himself. Joshua?
Good morning, good afternoon, good evening, wherever you are. Joshua Limo is my name, from Population Services Kenya, Health System Strengthening Manager, with great experience in terms of private sector engagement, spanning for almost 10 years. Thanks, and I'm ready and glad to be here to also engage. Thanks, and over to you, Wendy.
Thank you so much. Joshua is also a member of the National PPM Working Group in Kenya, and he will be assisting me to answer questions, or should there be any challenges, we'll be able to address this together. I'm quite excited to talk about the critical role that the private sector plays, and I hope we will all have an opportunity to learn from our lessons so that we together can advance the TB control. The private sector really plays a very key role, and we'll see as we go ahead. And while I do this is how I'm going to present this work. We'll talk about the role of the private sector and how the WHO guides us through the PPM roadmap. We'll also talk about the current TB landscape in Kenya and the opportunities that do exist. I'll be able to showcase a few case studies based on what we've done and the lessons we've learned, and eventually we're going to do conclusion for all these and hopefully have some takeaways. So to begin with, As I just earlier mentioned, the engagement of private sectors is quite critical towards expanding the TB case detection and advancing the overall health response, not for Kenya alone, but for all health systems. And the private sector really provides a fast point of contact for very many patients. We will have an opportunity to see how patient pathways look like. And this is similar for Kenya and other countries. In fact, in a landscape analysis that was done by WHO in 2018, it showed that nearly 75% of patients first seek care from the private providers. And the expenditure quite represents a lot on health, yet we continually, miss out on engaging the private sector. And if we do, we actually are not optimal in how we engage the private sector. So a lot of our countries suffer missed TB cases, delayed diagnosis, and quite persistent lack of engagement as well as underreporting. And these are opportunities that we will show on how Kenya has been able to handle these issues and how we've been able to document changes over time. The WHO PPM landscape actually identifies the engagement of the private sector as a key tool towards bringing everybody on board. Towards one, standardizing TB services, because at this opportunity, we have the opportunity actually to align with what the TB programs describe and ensure that we have consistency for quality care and for services across all sectors. But because we are also missing quite a lot of TB cases, then we have an opportunity to bring private partners on board so that we also have an opportunity to expand our diagnostic capacity. Now, as we expand our diagnostic capacity, it is not limited, as you're going to see. Not just, the private sector is actually very vibrant and is quite advanced in terms of discovery of new tools and such like. So it's very important that we leverage on the expertise within the private sector so that we're able to expand the diagnostic capacity. In addition, a lot of our surveillance systems leave out the private sector case contribution. Yeah. So in an analysis that again was done by the AU NEPAD, we realized that in the when we took stock take of the underreporting that does happen in most countries for TB and for any disease in that matter, we realized that the private sector usually has that leakage of the cases that end up being notified, but also end up being addressed within the national TB surveillance system. And honestly, it's very important that we provide a great range of care options. Even you yourself, when you go to a supermarket and you're buying something, you want to compare these. Sometimes you may end up picking what is expensive, but that's what you feel you want. So it's very important to deploy a range of options, and so that our patients can access care wherever they are feeling comfortable. And eventually we end up reducing a lot of stigma, but also increasing the treatment adherence, because then you have an option of where you want to be treated. I know most often within the government systems and most systems will say we'd want to ensure that you take treatment to your nearest public facility. But private facilities also offer quite good outcomes at the end of it all. So this is the roadmap I was talking about. This is a WHO PPM roadmap that is actually under revision currently. We are likely to launch another roadmap soon. This was a roadmap that was done in 2020 and revised thereafter. But we are hoping to have this launched very soon. And it gives us 10 steps in which we can engage the private sector, but also take care of the private sector. But first, it starts by saying we really need to understand what the patient preferences are or the dynamics within the private sector, so that even as we engage them, we are engaging them understanding what they have, what opportunities that there are, or what challenges they do. And this is most oftenly done through patient pathway analysis. But we also need to set ambitious targets for PPM. At the end of the day, advocating for political commitment is very key, so that the private sector is not just, we're not asking the private sector to come on board to just help us do 1, 2, 3 things. We are also bringing them on board to also offer what they have, because they do take care of our patients. At the end of the day, it's in our interest that we ensure that our patients are all managed well, but also allocate adequate funding for engagement of the private sector. This is where people are not quite very happy with, because the private sector is there for business. But it's very important that for sure we allocate some resources, and I'll talk about that later. Building partnerships and capacity so that we are working seamlessly. When we had COVID-19, our systems were quite hardly hit. But at that time, we were leveraging on anyone who has anything, and the private sector really played a key role during this time. But we start by establishing supportive policies and regulatory frameworks, as I'll show with you, but we have to be very flexible, yeah, and dependent on the local context. So like in Kenya, we realize that we cannot engage all private providers the same way. I'll show that as we go along. You have to really be flexible in how you adapt them. For them, they're there for business. So it's in your best interest, especially if you're working within the government sectors, to ensure that they are engaged well. Then, of course, harnessing the power of digital technologies. Most often, the private sector has, these robust systems of digital technologies, and while the government most often has a huge registers that can fill a table, and sometimes the private sector feels like they don't, they're not aligned to that because they are digital end-to-end. Financial incentives also play a key role, but also be able to monitor progress and accountability. So, as I was saying earlier, different kind of providers play a different role, and they all are to be engaged differently. So in Kenya, we have 5 models that we engage the private sector on. We have the pharmacy model, the informal service provider model, the diagnostic that includes both standalone labs and imaging centers, workplaces, as well as institutions, the already established institutions and private providers. And as we engage the private sector, there are components that we, again, I said earlier that we must ensure is at the bottom line of our discussions. One is the supportive policies. It's not enough that we just say we will engage. We have to have proper mechanisms on how we engage the private facilities so that we ensure that our care continuum is well established. Training. This is one of the areas that we had quite a lot of lessons learned during COVID-19. Sorry. The way we provide training for the public sector is different in how we provide training for the private provider. So we really have, one size doesn't fit all, so we have to be quite dynamic in how they access trainings. And for them, they have very many options that they provide, but also build diagnostic networks that include the private provider so that we are able to have everyone linked to the same system, incentives, reporting systems, and quite great referral processes. Now, Kenya is one of the high burden countries, and as a significant burden of TB, HIV, as well as TB, but is also a priority country for drug resistance. Over time, we have had a significant progress in reducing the TB incidence as well as mortality. And in 2023, this is data from WHO. In 2023, we had an estimated 124,000 people who fell with TB, but our systems were only able to detect 94,000 cases. So we end up having quite a lot of people, over 29,000 people, who are either not diagnosed or not notified within our system. Just like in most burdened countries, our bigger population of those who have TB is within the men compared to women. Now you can see there remains quite a considerable gap in identifying those who have TB, and you can see our TB HIV co-infection rate also remains a challenge. When you look at the mortalities, of course, we have progressively reduced our mortality rate, but still we are not out of the woods yet. Quite a lot of significant change, but still we end up having close to 8,000 deaths with TB annually. In 2023, 8,000 people died with TB. When you look at the diagnostic space, so you'll see a lot of inequitable access. Yeah, if you look at the map of Kenya, that is on your left, you will realize that a lot of diagnostic placement is within the central western region, and the northern, especially the northeastern, is quite, the southeastern part is quite underserved. So we have quite a huge number of health facilities in Kenya, but only over 14,000, but only 5,000 sites are treatment sites. And among them, only among these health facilities, 50% are actually private health facilities. But when you look at the number of diagnostic capacity, especially molecular gene expert sites that are within the private facilities, is just 7%. Yet you will see that patients rather visit the private facilities first. But it also depends, even as we ensure that we have quite a huge access for gene experts as the first test, then it's very important that we ensure that the quality of samples being addressed, as well as the packaging procedures, networking, acceptable turnaround times, as well as the relay of results. It really is dependent on that. When you look at our case finding in previous years, we have had quite an up and down, I may say. In 2016, that's when we did our TB prevalence survey that showed that we were missing nearly 50% of our cases, and we intensified case finding. And this is when we really were robust actually in engaging the private sector. And as you can see, we increased case finding, but as what happened with the COVID-19 period, we had a dip in case finding, and I believe this is the situation in most of our countries. But over time, of course, we've continued to intensify efforts and increase case finding, because those cases, that stigma that was, according to etiology during COVID, eventually people ended up hiding that cough, and you can see this cough, I think, was TB, because we continually, as a country, increased case notification thereafter. You can see over the last 4 years. But now I want to draw your attention to the graph on your right, which talks about the number of cases or notification contribution by private sector, as well as referral by private sector. So you can, most often people just judge the private sector in the number of cases they notify, but that's not enough. They are screening and sending, and we never used to track that indicator as much. And as you can see, from 2022, we improved that to 5.2% that were referred from the private facilities. Now in 2024, we don't have published data on this yet, but it's quite significant. Our contribution is actually up to 22%, and our referral by the private sector is actually up to 7%. So quite very impressive, and these are lessons, and I'll be sharing about lessons that we've learned over time now to engage the private sector and how it's working for us as well as challenges. We developed a dashboard that we've been using to monitor the implementation of PPM activities in the country. And in 2023, we put some targets as we were doing this to, first of all, it's very important that we just focus on first engaging the private providers. We engage them, we capacity build them, provide tools for them, then now be able to monitor the service coverage within the private facilities. Also look at the number of cases they contribute, but that's not enough. For us, it's very important that we ensure that at the end of the day, they could document a proper outcome for our TB patients. So as you can see, we hadn't gotten to the number of providers. We were hoping to have at least reached 30% of our private sector providers, but we achieved 27%, not bad, because we were coming from 23%. The proportion of engaged private sectors having an e-system in recording and reporting. So we've been selling these analogies so that private sector is quite robust and quite dynamic. So we said, let's provide for them a e-tool to be able to record and report. We were coming from a baseline of where we didn't know the actual numbers of private providers using an EMR or an e-system, and we were able to achieve 29%. Based on those that we upgraded their EMR systems to be able to capture TB screening and diagnostic and treatment questions and such like things. In terms of the service coverage, at least those who can have an initial access to WHO recommended diagnostic tool are close to 50%, which was quite something, because previously our diagnostic access at the private sector, before we put in mechanisms for referral and linkages, creating hubs and spokes, was just at 36%. Now, in terms of contribution, we were at 19.4%, which was an underachievement from 25% target, but I'm eventually hoping that we'll get there. In terms of treatment success rate for DSTB, we are 88, quite comparable with the private public sector, but we did very well in those patients that were managed in the DRTB clinics. But when you look at the HIV co-infected patients that are seeking care within the private facilities, we weren't doing quite well. And when you compare those that are in the public facilities, our death rates were higher compared to the private facilities. So this leaves a question: is the quality of care within the private sector as adequate? Are we, if it's the government, is the government or the institutions, the national TB programs, providing adequate training or policies and guidelines to the private sector as often? And this is the rationale why we engage the private sector in Kenya. As I earlier said, close to 50% of our health sector is the private facilities. And in a patient pathway analysis that we did in 2017, it showed that our patients first seek care within the private facilities. And among those ones, 7% of them could not access an adequate diagnosis. I'll show that in my next slide. But also the TB prevalence survey showed that the 21% of the TB prevalence cases initially sought care within the chemists and the pharmacies within our local communities. So over time, we've had action plans that are helping us engage the private sector, as I earlier said. So when you look at the patient pathway, you will see that, yes, close to 42% of our patients are going to either the informal or the formal private providers. But when you look closely under this section 2 on diagnostic availability, these are the people who are still not accessing quite a huge, an opportunity to get diagnosed. So there's quite a lot of mismatch between where patients seek care first and eventually where the diagnostic tool is provided for them. So how does this partnership work? We first do engagement. So engagement involves mapping and selection of facilities. But as we do the mapping of these facilities, we also have, we map their strengths, we also map their gaps, so that even as we engage them, we know how to actually engage them effectively. An engagement is usually through a memorandum of understanding. Our governments are devolved, so within the county government, so the private providers sign an MOU with the county government, whereby it indicates that you will provide services for TB, and in return, we are going to provide the tools, the training, the commodities, and such like things. And that's how we support the private sector. We also provide reporting and documentation tools, offer or link them to the existing mechanism for sample referral and diagnostics. And then if you're diagnosed with TB, we provide essential medicines and commodities. And then, of course, the private facility continually benefits from supervisory visits, as well as capacity building and mentorship. And what is required of you is that you use the National TB Program approved policies, guidelines, as well as documentation tools. And then our coordination at the county level is through a PPM COE, but of late we are integrating. So it's a integrated COE, committee of experts, of what we call the technical working group. And at the national level, we have a very robust technical working group that handles this. But we, as earlier said, everyone is not engaged the same way. We have different task mix for different providers. So there are those who just screen, presume, and refer. There are those that are able to presume, run a diagnostic test, and initiate treatment. There are those that are only able to diagnose and refer for initiation of treatment. And what is expected is that once you conduct the TB screening, you're able to link all of them to a diagnostic test using the diagnostic algorithm that we've provided for the country, ensure that patient is initiated on treatment and notified, and of course do contact management for those that are bacteriologically confirmed, and ensure there is proper documentation while at it. So one of the case studies that I wanted to share today is digitizing private sector data. As I earlier said, WHO helped us develop a PPM dashboard that enables us to share data between the private facilities and the public, so that then they consume this data and they use it to inform change. We also did an app-based solution, which is called Tibulite. Our national surveillance system for data is called Tibu. So Tibulite is an app-based solution, and over time we've been able to increase the number of private facilities. So in 2022 compared to 2023, quite an increase in the number of facilities that are enrolling. And in the private sector, last year alone, we increased to up to 23,000 people were able to install, but also 7,000 cases that were notified within the private sector. The community health volunteers, community health promoters are also able to use these tools to guide engagement within the private sector. We're also targeting the workplaces for men. So this has been a very interesting one of the engagement of the private sector. Reaching out to workplaces and talking to the management to, adopt the TB within their occupational and safety health policies, and come up with a workplace policy. And this one was very interesting because we ended up creating quite a lot of awareness within the workplaces, screening them and linking them to diagnosis, but also having workplaces actually support TB treatment adherence by having the TB champions, and also offering incentives like paid work, work leaves and such like things, to be able to have compliance for TB. Then in terms, and when we look at the data for men that, data for the workplaces, we were actually able to reach more men compared to women. And you can see just a snapshot of how we were able, the cascade with time. In case study 3 is when we decided to increase the diagnostic access for the private facilities through a hub and spoke model, just focusing on linking the private facilities to digital X-ray hubs or gene expert and TrueNut machines. And we saw quite an increase from bacteriologically confirmed TB patients from 38% to 44% in 2023, and increased outcomes from 86% to 88% in 2023. We also had an initiative that was looking at communities, which I've included here. But here I just wanted to demonstrate the yield that we got from engaging different models of TB control. The chemists and the pharmacies, you can see we weren't able to screen as many people, but you can see the number needed to screen within the pharmacies and the chemist was lower because the yield is quite high. But you see again, we were able to test more from those that are in communities, but the yield again, the number needed to screen was also good. So you can see, depending on the model that you engage, the number needed to screen is dependent, but eventually we were able to at least have some patients get on treatment and quite some advancements that were done on this. So what is it that we achieved, or what are the lessons that we learned? It's very important to have a coordination mechanism, and we did this through a PPM action plan, also harnessed on the power of digital technologies, that is both TIBU and TIBU Lite, but also ensured that we provided standard guidelines as well as reporting and tools. But it hasn't been easy because we still need to adapt flexible models for them, especially extending to other sectors. So like in some of the workplaces that we visited, like I remember one of them was the Ministry of Forestry, and they really didn't understand the concept of why it's necessary that we go to workplaces. When someone is sick, eventually they'll go to hospital. So why are you coming to the forest department? It was quite very strange. But then at the end of the day, when we notified, like after months of creating awareness, like I think 4 months, one of their colleagues was diagnosed with TB, and eventually they saw the need of at least having awareness and such like things, but also ensuring that we have the active engagement of the private sector itself. So it is not enough that you are planning to engage the private sector. It must be towards modeling solutions of their, of their gaps that they have with time. The challenges that do exist, of course, it's low prioritization of TB among the private providers, but also within governments, because it's a two-way approach. So most of the time, the private facilities will feel like, that TB services are offered within the government facilities and it's not profitable. So we really try to bring in a business case for them. We actually, within our PPM action plan, we outlined a business case for them so that they see why it is important to engage in TB control activities. And for the public, we actually have a champion. Most of you may know the former president of the union, Professor Chakaya. He's actually the champion of PPM in our country. And that he helps bring other private providers, or also call to government to ensure that we've increased resources and funding towards PPM. Then in terms of the mapped and unmapped facilities, so the private facilities mushroom any day. There's always a new private facilities, and it becomes very hard to engage them. But also there's a lot of inconsistent care due to high staff turnover. There's always the greener pastures elsewhere when you're in the private facilities. And most often they're not provided with the standard practices. And for us as a country, what we provide to the private facilities a rapid orientation package, such that should you find yourself in this facility today, and you do not know what happens in TB, there's a quick reference, which is called a rapid orientation package, where you're able to quickly view. It's quite a small booklet, but it's also available online, and you're able to do that. And then, of course, the limited capacity for DRTB within the private facilities, as well as TPT, but also the fact that we provide too many tools. I don't know if it's our country only, but the TB tools are quite many and huge. So yeah, the private sector really suffers with that a lot. So in terms of lessons learned, it's very important that we integrate TB with other health services, so that you're able to cross-subsidize for other program areas, but also map as many providers as possible, including their gaps, so that when you're addressing them or ensuring that you're reaching them effectively, their gaps are also addressed. But also ensuring that you have structured and advocacy and engagement. When we started engaging the pharmacies, what happened to us is that we would go to a town and tell ourselves that, oh, today we are going to this town, and Joshua did a lot this with me. We are going to engage, talk to all the pharmacies and chemists and tell them why they should onboard and such like things. And immediately we left one chemist. All other chemists and pharmacies would be closed. Of course, it's the government, and the government just comes to enforce, regulations. So of course they would think we are coming to enforce regulations. So we realized it wasn't working. So we started engaging the professional associations for pharmacy, for pharmacists, and and it worked. Because now their professional body of pharmacies would call them in that locality and tell them of new advancements in TB, and then of course that way it's different. But going in as government, people still don't trust the government at times. So especially business owners, because of the role the government plays in enforcing regulations. So it's very important to ensure that that is done in a structured way, and a lot of advocacy so you get buy-in. In terms of capacity building, very important that we define the roles of different providers. There are those that will just screen, there are those that will test, there are those that will screen and offer diagnosis capacity and just refer, but there are those that will do all the rest, screen, make a diagnosis, and initiate treatment. But there are those who will just offer dots. Like in COVID time, we realized that the community pharmacies were really working to our advantage as dot centers, and it worked very well. Then we ensure that we have comprehensive integrated training that is very purposive for the private sector. So the private sector ends up missing a lot, but also reaching them in a way they desire is very important. In most of the private facilities within the capital of Nairobi, require us to reach them very early in the morning. So you realize that we have CMEs in the mornings, a lot of sensitization forums very early in the morning, and we go in as early as 6 a.m. Yeah. Sorry. We go in as early as 6 a.m. in the morning, and by 7:30 we are done. And then at that time they are able to, reach out to their workplaces, provide interesting IEC materials, information and education communication materials that are easy to access. Most of these private facilities really want their walls very clean. You know, they're very high-end private facilities want their, you know, their walls very clean and looking flashy. So you have to provide for them mechanisms in which they can adopt. You know, they want their branding, just provide for them information so that they can brand it as they wish. Then, of course, innovative capacity building models that I was speaking about, including virtual meetings and echo session that we do have. We also have WhatsApp discussions. We have mechanisms within different TB control zones where we have experts that join in to help, you know, discuss challenges and you know, things that are happening on a daily, you know, and on a daily basis. The private facility will post in that WhatsApp group that I have a patient who I think is presumed to have TB, and I'm not able to reach the rider today. What do I do? And of course, there's always people having active discussions and, you know, such like things. In terms of our county governments, they play a very key role in towards onboarding private facilities to either treatment sites and upgrading them. And in fact, upgrading them for them is actually an incentive. They actually really feel recognized when we upgrade them, because for them, they say, you know, we are working with the government towards this, and it's quite encouraging for them. In terms of reporting and documentation, very important that you have a tailored tool that focuses on different providers. Like for the standalone pharmacies, are very short. This is like a shop, really, if you look at it. So this is someone who, that's not their business, really. So why would you want them to have a register from here to Southeast, you know, Kuala Lumpur? It's very important then you ensure that you have a very sweet and short screening tool, so that you also encourage them to screen. And that's why we provided the digital app, the app-based solution, where they just enter, this patient is just coming for a cough syrup, and you start screening them. So of course you provide mechanisms in how they can do it that are simplified, but also ensuring that one of the areas that helped us do manage information within the private sector is doing data quality audits, just to ensure that we have reliable reports that come from the private sector. Then in terms of referrals and linkage, please, if you're within the government system, ensure that the labs and the private facilities are linked to the existing mechanisms, especially through a hub and spoke model. It works very well, and I know countries here that have done that, and it's very good. Now, you can never run away from incentives. It doesn't have to be financial incentive. Incentives and enablers are very good and really encourage the private providers to participate in TB control. It could be monetary or non-monetary, it could be just recognition. Even capacity building alone is an incentive to the private facilities. Then ensuring that you have someone who is actively activating the cold spots and driving teamwork is very important, both at the national level, at the district or the county level is very important, and bringing them together annually, when we had funds before the stop work orders, we were able to bring them together to have a learning opportunity, to provide experiences. And when you're talking with one of your own, it slaps differently, or rather it just sinks in differently. Then of course we optimize what we are not able to have. So in terms of sustainability, the WHO has provided quite very good guidelines in how to adopt recommendations based on evidence, but also very important that we use our in-country experiences and sustainable solutions that we can focus on. But it's always very important that you embrace new innovations. And this then translates to having a model that works for you. For us, this is how we were able to have the five models: the private sector, workplaces, diagnosis, informal, and the pharmacies. It is based on the guidelines, the lessons that we learned, and then, of course, we wanted to adopt new technologies. In summary, it's very important that we sustain the mechanisms for private sector. So it's not just the private sector alone. We also need to link this to multi-sectoral engagement. Yeah, it doesn't just stop with the private sector. Other sectors eventually need to be committed towards TB control. Now, one is ensure, the takeaway home today is ensure that you provide frameworks towards engaging the private sector and how we're going to enforce the policies and the laws, but also ensure that we provide tools and commodities and supplies for them. Also, provide a range of various models to finance the private sector, organize them in such a way that they are able to adapt to what the governments are saying, or even ourselves, if we are the private providers, we have a role in ensuring that we plug well to what the government is providing by recognizing that there is a benefit in engaging in TB control activities. The use of incentives and enablers is very key. It really encourages both patients and provider participation, but also digital solutions to visualize data and to promote data demand is very important, and then it enables us to engage the private facilities very well. It's very essential that we continue to engage the private sector because, as Adlia said, we have a lot of inconsistent care that is existing within the private sector that we really need to address. Allow me to stop at that point. Thank you very much.
Wow, thank you so much. Thank you so much, Dorote, for your insight into what Kenya is doing about the public-private mix in terms of trying to support TB control. And I think you have highlighted a couple of things that have actually incited the participants to raise a couple of questions. So you mentioned all the different models, what have been the benefits, the challenges, and the different cases that you tried out there. Thank you so much. And I would like to let you know that from what you've presented, a lot of questions have come through. We have only 12 minutes left, and I hope we'll be able to respond to all those questions. I'll be asking them, some of them join together, and you'll be able to, hopefully, you'll be able to respond to some of them. And we encourage colleagues to continue sending in some of the questions. So if it's fine with you, we could start with the quick questions that have come in from people. I'll be reading them out to you, and then you respond together with your colleagues. So the first question we have here is that is from Z. This question is, I'm just wondering why the WHO PPM seems to be for TB prevention and care instead of it being transversal for other conditions so as to promote greater collaboration between private and public sector, unless there are other PPMs for the other conditions. May you please respond to that, and then we can go next. Thank you.
All right. Thank you very much, Z, for that question. So the WHO TB PPM was a mechanism towards addressing the fact that we were missing quite a number of cases, generally in the world, and in most countries, patients first seek care from the private facilities. So, as you know, TB is quite very highly, infectious. So we realized it would be very important that where these patients, the TB patients, are first seeking care, we reach them wherever they are. But that doesn't actually mean that the WHO does not have mechanisms to engage the private sector. No. There is a PPP, the public-private partnership, which they've now transformed to public-private collaborations, there is a framework that guides on how to engage the private sector towards not disease control alone, towards capacity, towards the resource mobilization, towards financing, towards service delivery, and such like things. So there's a PPC, a public-private collaborations framework that is also anchored under the multi-sector engagement framework. So the multi-sector engagement framework also calls out to all other sectors to contribute to ending diseases, not just TB alone. Yeah, so there is that bit that is out there for other diseases, but this WHO TB PPM was very specific towards addressing TB. I hope that answers.
There's another second question from Robert. I think this one is being gender sensitive. Robert Matobi is asking, why is it that there are many more reported TB cases among men compared to women? Are you able to respond that quickly, and then we go to the next one?
Oh, all right. So, okay, sorry. You see, yeah. So the TB a lot among men is usually because of their health-seeking behavior and their social behavior. Most often, you realize that men hang out in clubs, and the work they do predisposes them. A lot are working in the mining sector, in the transport sector, so they end up getting exposed based on what they do or where they are spending most of their time at. So that is what predisposes them to TB. While you realize that women have better health-seeking behaviors compared to men.
Thank you. I'm bringing to you two more questions. I'm going to combine them. The first one is from Henry Dixon, and it's asking, the private sector is usually there to make profit. What strategies have been used to mobilize the private sector to contribute to TB cases detection and reporting? Then the second question from Anonymous is it compulsory for private sector and even public sector to report new TB cases to the national surveillance system? Thank you.
All right. So yes, what mechanisms are there to ensure the private facilities are onboarded, yet they're there for private? So one of the mechanisms that we have used in our country is identifying the business case. There's what we call the business case model for TB. So this one talks about the reason why every patient who sought care in your facility chose to do for you as a private provider. Yeah. So there's a patient who came and sought care in this private facility. So that's where they preferred. Yes. So if you lose them by referring them, you end up not getting the financial gain when they have any other condition. So it's like you're in business and you're referring your client to another competitor, So when you are maintaining this client, even if they have another issue, may it be stomachache, they will still seek care there because you are able to address them. And eventually, that is a benefit to the private facility. So they are coming in today with TB. The ministry will provide all this care. So you may not benefit as much. But this patient continues to come even for clinics, and you're charging the user fee. So either way, it's still a benefit to the provider. Now, is it compulsory for TB in Kenya? Yes, it is compulsory. Based on the Public Health Act of Kenya, the Kenya Public Health Act under Cap 242, it is mandatory because TB is an infectious disease. It is mandatory for you to notify a TB case, and it's punishable by law if you do not notify a TB case. Now, how we enforce that is what has been a challenge for us as a country. Yes?
We have still more questions. We have only 4 minutes to the top of the hour, and we need to end it at 19, but I'm going to combine about 3 to 4 questions.
Your volume is going low, Silva. Okay.
Is it better now?
Very clear now.
Okay. So I was saying I'm going to combine about 3 to 4 questions. One is from Ray. Do we have platforms that are used for MDR and XDR? how are you handling second-line drug resistance? Maureen says, do you also track and report referrals from public to private facilities? I think you answered that, but maybe you need to comment on that. And then also from Innocent, kindly share insights on your experience with regard to public sector referral linkages in the diagnostic cascade. What strategies are you employing to ensure all presumptive cases have access to WRDs and eventually treatment initiated?
Okay, great. So I'll start with the latter. In terms of referrals and linkages, so these have not been optimal. We are still struggling with these as a country. So we created hubs and spokes model of whereby we have the private providers linked to a public facility that has a molecular WRD. But that still ends up not being very effective because naturally the public sector takes care of their major patients because that's where the many patients are seeking care first. So it ends up not being optimal. However, we've been able to track, and in one of the slides that I showed, in 2023 compared to 2022, we were able to have an increase in the number of patients who access WRD within the private facilities, as well as the referrals from the private facilities. Now, when you're referred to from the private facility, let's just assume you got screened and were referred to the public facility for care. When you get to the public facility, unfortunately, most often you're noted as self-referral. So we end up losing that private sector referral. It is not all rosy. It hasn't been very 100%, but we are continuing to keep the gains. Now, for us to improve the WRD access, we have increased also our placement of our gene expert sites, gene expert machines, as well as our TrueNut machines within the private facilities, and especially the faith-based, because that's where we have a lot of high volume for patients. We are also linking them now based on the sample referral network. We are linking them to other facilities. Let me not deliver on that so much. Let me speak about the tracking of the referrals. We have tools that we're able to use. Our tool has that ability. Where were you referred from? So yes, the private sector, so we indicate that, but we end up having losses. In terms of the platforms for XDR and DRTB, how do we manage these? We have a clinical team that is able, in every TB control zone, we have a team that is able to address the drug-resistant TB patients that is quite clinical. It's a comprehensive clinical team that is able to manage these patients. But for private facilities, are also linked to that clinical referral, clinical management team that manages all TB patients. Allow me to, I know time is quite over, but allow me to talk about one of the things that I had seen from Nyombi that spoke about the distribution of medicines and commodities to the private facilities, yet their profit, and how do you monitor the stock levels? So we have a main mechanism that tracks commodities from the central stores, which is a medical supplies agency, to the district stores. So this is done through a TB monitoring tool or a TB allocation tool that shows us the number of patients that are notified within different facilities. So you're given your medicine based on the number of patients that you notify. So you do not report, you do not get. You report, you get. So it's the same for private facilities and for public facilities. Thank you.
Thank you so much. And I think our time is fast 10. We are at the top of the hour. I know there are still more questions to be answered, but because of time, maybe I'll be able to answer one. But we encourage colleagues for the poll of the session, be able to respond. And I will be forwarding some of these questions to our presenter to be able to answer all of them and then be shared in our different platforms. It has been great hosting you, colleagues, and would like to let you know that you should be able to download your certificate for attending this session. And at this time, we'd like to appreciate our presenter and sharing the experiences from Kenya. And I would request you, maybe you give us a parting shot, and within the parting shot, you respond to one of the comments raised by the colleagues that given the recent global funding challenges that have come up, what are some of the experiences or possibilities that the private sector can step up to address some of these TB issues? Maybe a comment on that, and then we shall be closing shortly.
All right, thank you so much. Okay, great. Thank you so much, and I really appreciate the opportunity to be able to share experiences from Kenya. It's been quite amazing. I'm very passionate about the engagement of the private sector towards TB control, and we can all see the private sector really plays a key role. We just need to be intentional in how we engage the private sector, but we also need to ensure that the services that are provided across, may it be public, private, all services are of quality, and everyone, all people can access services from wherever they want. They have ability to seek services wherever they want, and wherever they get those facilities, then they're able to, access quality services. In terms of the recent stop work orders, it is going to affect, of course, a lot of our health systems. But it's very important then that we build resilient systems. Yeah, our systems need to be resilient, and we need to start, financing our systems very well as Africans. It's very important that we are very we are very intentional towards, even calling out for our governments to allocate resources and to be able to allocate, especially to healthcare, is very important. We haven't reached the declarations on financing health systems for all our African countries. So I believe this is an opportunity for us to reflect so that we are able then to do more and put in more. And I hope even this is a lesson to be learned as we go along. Thank you, and over.
Thank you so much, Jerote, and colleagues. Thank you so much for sparing your time to attend our users echo sessions. And on behalf of ASLM and all its partners that make these echo sessions possible, we'd like to thank them. And to also let you know that we are having more echo sessions coming in the near future. Our next session is on the 21st, or check your inbox. This information will be coming to you. I have been your moderator, Mashate Silva, working with ASLM. Thank you for your time, and we look forward to the next engagement in the near future. Thank you, and bye-bye for now.